So let me introduce Robert Holden, who's going to be our first speaker from Stateside Associates. He specializes in healthcare and professional licensure, regulatory issues, and manages Stateside Associates' healthcare issues practice. He monitors legislation, regulations, and helps clients roll out new products and services that meet regulatory requirements. He'll be doing an update on a lot of things that are going on that are going to affect concierge and direct practice medicine at the state level. He's worked with members and stakeholders of the National Council of Insurance Legislators and developed benchmark legislation. He's also worked with the National Association of Insurance Commissioners, the National Council of Insurance Legislators, Association of State and Territorial Health Officials, and National Association of County and City Health Officials, the National Association of Medicaid Directors, and the National Association of Regulatory Utility Commissioners. So he's very well versed in what's going on locally and statewide. Bob Wood, the second speaker, his experience includes serving as Secretary Thompson's Chief of Staff, both during his duration as Governor of Wisconsin and later when Thompson became Secretary of HHS. He also served as the department's chief liaison to other federal departments, governors, and the White House. He's managed daily operations, one of the largest departments in the federal government. Since joining BGR, Bob has used his state and federal experience to lead numerous campaigns for public policy efforts, which require insight about engaging lawmakers, as well as activating grassroots and community support programs. So I'll turn it over to Robert.
Thanks, Bill. Good morning. I'm Robert Holden, and there we go. One of the things that I wanted to talk about this morning is really an outgrowth of the Affordable Care Act's implementation. The states, while Bob is going to get into a lot of federal issues, the states have basically been digging out in terms of implementation and some of the unforeseen ramifications of the Affordable Care Act since 2010, and this upcoming legislative session will be no different. One of the key issues that they've been trying to figure out recently has emerged because of the medical loss ratio portion of the Affordable Care Act. And there is and has been an incentive for insurance carriers to really streamline their networks, to cut down on administrative costs, because that cuts in directly to their profits. The medical loss ratio caps, depending on the size of the carrier, to 20 or 15% of their overall premiums. So they've got to make their money out of that 15%, and any overhead cuts into that profit. So what they've done is they have streamlined their networks. They've cut some expensive providers out of those networks. They have really tried to eliminate any extraneous costs that they can from their overhead there. And as a result, there has been a major movement really starting in 2015, but even in late 2014, to combat that from a regulatory standpoint. And we've had a lot of advocacy organizations, AMA and many disease and patient advocacy groups have been really lobbying the federal government, but more intensively the state governments, because that's where most of the regulatory authority lies to control network adequacy. And so what we've seen are states that are looking to use regulation to provide care options, and I guess there's a little issue there, but also states are looking at transparency issues that are caused by some of the network changes that carriers have made. They want to make sure that as patients look to either purchase health insurance, or if they're just trying to find a physician, that they can get access to directory information and other information in a transparent way. Furthermore, there are some other ramifications that we'll get into in a moment, which are requiring physicians to inform their patients of their relationships to various networks and facilities. So the main issues that are consistent across all 50 states that legislators and regulators are looking at are this narrow network issue. And as I mentioned, the way that states can control that is by making sure that carriers have adequate networks. And they have very specific time and distance standards that they apply. They also use third-party accreditation standards, NCQA, URAC, to make sure that those networks represent an adequate number of physicians and other providers and specialists to properly care for their patients. Additionally, states have been looking at professional scope of practice and licensing issues. In many instances, expanding scope of practice for non-physicians so that there's primary care access, and we'll get to that in a moment. And then the third big issue that states have focused on is opioid abuse. This was an enormous issue at the state level prior to the Obama administration taking an interest in it recently and putting a focus on it. It is one of the most emotionally charged issues at the state level for legislators. They put an immense amount of focus on this, and they have tried almost everything that they can think of to combat this. That's something that's going to take up a tremendous amount of time and interest in the upcoming legislative session, and certainly has this year and in many years previous. So I want to talk first about the narrow network and network adequacy issue, because there are a number of issues that emerge from network adequacy that you might think are different, but they're really stemming from that same core issue. One of them is the provider directory issue, making sure that patients and enrollees and anybody who's looking for coverage, either by purchasing a plan in a state exchange or in any context, have access to information about the providers that are available to them and the physicians that they can work with. The other issue is surprise billing prohibitions, and that's something that states have put a focus on increasingly over the past few years. Again, it's intensified by more physicians being out of network, particularly in a facility-based context, where patients may see someone, even if they've done all of their due diligence as they can from a patient standpoint, they may be treated by someone who's out of network, and they're getting a bill that they weren't expecting. And that's something that state legislatures have been focused on, and we'll see a lot of legislation on that. And then there's out-of-network notification, and that is something that for this group probably is something that's going to apply more often than not, and that is making sure that the patient knows when certain treatments and other things are out of network or in network. That's something that states have taken a very broad view of and are putting into effect a large number of facility-based requirements when you see patients in a hospital or any other facility setting, that they are provided at the time of service or even a few days before notifications of what their rights are, who's going to be treating them, making sure that all that information is very transparent for them. And we'll talk about that also. So just to give a historic background on what's been going on, again, as I mentioned, 2014, really, we had New York lead the way in terms of trying to come up with a legislative solution to additional transparency with regards to networks. They had their comprehensive bill, Assembly Bill 9205, that passed as part of a much larger, actually part of their budget bill, but that passed in 2014, and that requires a tremendous amount of notification, both from the provider and from the carrier and from anybody else who might have either some sort of review or management oversight over whether or not a particular treatment is covered or not covered. They have to provide notification not only to the patient, but carriers and other entities have to make sure that the physicians are notified anytime anything has to do with an in or out of network coverage determination. And at that time, they also, knowing that additional billing and balance billing was going to be an issue they wanted to attack in terms of trying to prevent that sort of surprise bill, they came up with some language that required really sort of baseball-type arbitration between the physician and the carrier, trying to come up with a settlement for non-covered services or out-of-network services. And as a result, that started many states looking at that issue. And it was taken up by the National Association of Insurance Commissioners in 2015. which is, as an entity, is very influential in implementing state policy as it affects the Affordable Care Act implementation. They're one of the only non-federal entities specifically referenced in the Affordable Care Act. And since really 2011, they have been working night and day trying to make sure that state laws are in compliance with the AOA and giving guidance to insurance commissioners to make sure that there aren't any additional issues as a result of the Affordable Care Act. And so they have been systematically going through all of their model bills and regulations, which most states adopt. And in the case of their Network Adequacy Model Act, I think all states have enacted versions of that. So they went through, and we were part of this discussion, they went through their entire Model Act over the course of a year and a half and enacted their final at the end of 2015. And there were three major components of that. One was the dispute resolution requirement that really had its start in New York, although other states have done it as well. They also went a further step, suggesting that it might be worthwhile setting a benchmark level of reimbursement. They suggested Medicare, but did not limit it to that. There are any number of underlying fee schedules that they said a state might use just to get to an agreed upon reimbursement rate that could be referenced and negotiated off of. So again, they didn't put anything firm in there, but they did suggest that as an option. The other, again, was patient notification at the time of service by the provider and then also by the carrier at enrollment. And then provider directory requirements, as I mentioned. So all of the issues that I mentioned earlier came out of this model bill as a reflection of discussions that were going on in the states. So in 2016, this legislative session, we saw over 40 proposals at least introduced. Not many of them enacted at this point. I think that there is still some effort on behalf of legislators to really understand all of what the ramifications of what they're doing. But we did see some states enact a variety of things with a relationship to that NAIC document. Connecticut, Maryland, and Utah all adopting the components of that NAIC model rule in their statutes. Connecticut and Florida also enacted balanced billing measures with regard to extending notification and their dispute resolution programs. And then Connecticut, Georgia, Maryland, and Minnesota enacting provider directory requirements. These were all pretty much in line with what was discussed at the National Association of Insurance Commissioners, and certainly I think that those really reflect where most states are going to be in the upcoming legislative session. But more to the point and what we're going to be looking at moving forward, California, I think, has really led the way in coming up with truly comprehensive legislation to the point that I think they may have gotten ahead of themselves, at least trying to figure out how they're going to work this. But they certainly, just this past Friday, Governor Brown signed Assembly Bill 72, which set a benchmark for facility-based out-of-network services at either the average of the in-network fee or 125% of Medicare. So if a provider or physician, but non-physician as well, services provided in a facility setting that is out of network on an emergency basis, they will take a look at reimbursement at that average in-network fee, and they'll take into consideration the geographic area it's in, or they can go with 125% of Medicare, whichever is higher. And certainly there's been, the carriers have been lobbying hard for this, but also the medical associations, this is something that they have come around to agreeing with. It's one of the issues in which the insurance industry right now has an advantage in their lobbying effort. They are seen in a better position on this issue than physicians are as a group. That's really one of the few issues in which that ever occurs, as they're seen frequently as the bad guy by state legislators. But this is an issue in which they're certainly trying to find a solution to this out-of-network billing situation. And unfortunately, they're not looking at any sort of innovative steps or deregulation. They see this as their best option given our current system. Also, they set up a binding dispute resolution system, the IDRP, the Independent Dispute Resolution Program. That is not going to be ready to go immediately. That's going to have to be regulated. So the implementation date, or the effective date, I should say, for this legislation is July 1st of next year. But I would be surprised to see that IDRP system up and going at that time. I think it'll take a little bit longer in California, and I think that's going to be the case in most states. Also, they're going to collect a tremendous amount of information that comes out of that dispute resolution system, and they're going to incorporate it into their determinations in terms of network adequacy.
Robert, just a quick question on
Sure.
that bill. So it's only for facility-based services,
Correct.
but the private office will not be affected?
Correct.
Okay.
Right. Again, this was this has been identified as a hospital issue primarily, and even to specialties, anesthesia and radiology and other issues that may occur within that facility session on an emergency basis. So again, it's not broadly applicable just in that facility setting. The facility has to be under contract. The issue is the facility is in network, but an individual practitioner is not. And so they're out of network. And typically that's going to be in fairly narrow circumstances. But the applicability I think that you should be concerned with is notification of your patients. There will be some state requirements, and they're going to vary as this rolls out. That you're going to have to let your patients know what the situation is. You're going to have to make sure that they're fully apprised of those things.
CMA negotiated that.
Mm-hmm.
CMA was not in favor of it. This was a bill, a compromise bill, because of 533 last year.
Yep.
And this was one of their defensive postures, and they negotiated that none of the treating physicians outside of the hospital-based physicians would be affected by this bill.
Correct. But we've got a lot of other states that are looking at this idea, and frequently.
Oh, sure, it's a crappy idea.
Right.
But, you know, the CMA at least was able to negotiate that little bit of it.
Absolutely. So, again, this is going to be, I think, one of the leading sorts of examples of this type of legislation, but all the states are going to take a look at this, and there are going to be lots of variations on it. I think that the critical issues that these bills are going to address, again, the one that I think will have the most impact to you is that notification requirement, and they're going to vary in terms of from state to state how that plays out. Additionally, California enacted their provider networking directory requirements last session, and the Department of Insurance right now is working through the details on that. They need to get done by the end of the year. We'll see exactly how that plays out. I've indicated some of the information here, but I wanted to talk in general about what sort of new issues they're bringing up as a result of this. In the California law, there is, and this is something that was discussed at a national level as well, there is an appreciation that patients and enrollees need to know more from their network about the physicians that are available to them and the sorts of issues that come up from that. And so they're soliciting a lot more information to be put in those directories. However, at the same time, I think state regulators are concerned that physicians are not providing that information to networks. Certainly, they're getting complaints from networks and carriers that they're not being provided with that information. So increasingly, legislators are thinking that they need to find some way of encouraging providers to get that information to carriers in a timely fashion. They know how they can come down on the carriers. They can put a lot of penalties in these bills, and they're very comfortable with that, but they don't know how they can incentivize that information coming from providers. So again, that's something we're going to see play out in a variety of different ways, and we have a number of states. These are 3 of them that are having formal interim session groups in discussion, but we have a lot of informal groups in a variety of states. So just to go through some of these other issues quickly, because I know we're short on time. I beg your pardon? Yeah, sorry about that. So at any rate, we've got a number of scope of practice areas. The advanced practice registered nurses, pharmacists, and optometrists are all working hard to get their scope of practice increased in order to see more primary care patients. Physician licensure issues still are going to be a focus moving forward, trying to, in some instances, loosen up physician licensure to reduce issues there, but also tying licensure to Medicaid and other programs to make sure that they can get physicians into those networks. And then, as I mentioned, opioid abuse is something that a lot of states are taking a look at. All of the New England states are taking a look at that, and you've got a variety of different policy solutions that they're viewing there. So again, that's what I had, and thank you very much for your attention.
It's nice to be in a friendly room. It's not often that Tommy Thompson is mentioned, and as a side note, I am an MD VIP customer in Alexandria, Virginia. We go from the states where a ton of things happen and a ton of things get done to Washington, where we are in a political season and a lot of infighting, and the inertia is always against anything to happen. It kind of sets the tone of what we're going to talk about today. So Washington is winding down. They have 1 week left, and unfortunately they've left much of their work to still be done. So Congress is going to come back after the election, and a couple things that still could be, with most of their work still to be done. A couple issues that are, from a healthcare perspective, potentially driving some bipartisan changes are the issues of the significant premium increases, as well as the open enrollment period coming up, and the administration wanting a tightening of that. We'll fly through this. This is mainly process, but the point of this is that after the election, there is a goal to get some things done. And one of those is the Cures package, which would provide significant dollars for the NIH, as well as upwards of $1 billion for the Vice President's cancer moonshot, and upwards of $1 billion for state grants on opioids. The other items which are mentioned below, and predominantly the device tax, the health insurer tax, and Cadillac tax, which were delayed a year ago, again at the end of the year in a bipartisan agreement. The other items are unlikely to occur, but that debate, depending on the election, elections have consequences, are going to be a big part of the 2017 debate, which we'll talk about later. Other issues that are getting debate, there's a bipartisan mental health package. Again, I think difficult to get across the finish line. The CMMI Part B drug demo, there is a majority of Congress opposing this new action by CMS, which again, we're going to talk about that regulatory overreach. Value-based purchasing for post-acute providers. Again, a lot of activity in the Ways and Means Committee, definitely not getting done this year, but top of the agenda for 2017, and a couple other items that you'll see there. And if you care about other non-healthcare related items like Supreme Court nominations or trade deals, you can see those other issues that will get some attention in November and December. Everything in healthcare for the last 6 years has been driven by the ACA. And what that means, and again, you've already been talking about that, who really runs the show when it comes to healthcare decisions is hospitals and insurers. They are the ones that came to the table, they are the ones that worked with the administration to get the AC implemented, and they are the ones that are working to make the fixes to potentially continue the program. And I say potentially because most of us in Washington think that is completely in doubt. So this is just a reminder, something you're all well aware of, that you have a majority of the states are in the federal exchange in one way or another. You only have 13 states that are running their own state-based exchanges. And this, of course, mirrors political patterns as you would expect, largely based on Republican governors and Republican legislatures. So again, a reminder of the data. 20 million people in the ACA. The exchange enrollment is almost 13 million. The third bullet point, though, is really, which we're going to show you later, Medicaid enrollment has grown by 14.5 million. But that being said, the largest growth of the exchange has come from the employers, if you will, dumping. This is an important slide. It doesn't really illustrate the point of all this, but I want you to look at that. So that is the Medicare spend for the next 11 years from 2010. Medicare spending will basically double, and Medicaid spending over the next 10-year period is going to double, which is what is giving us this healthcare spend. When you look at other healthcare spending, relatively flat, and discretionary spending also by percentage. So entitlement reform is a big issue, very different perspectives in Congress. If you have a divided Congress, not much gets done. If you have a Republican control, and specifically a White House, entitlement reform, specifically around Medicare and Medicaid spending, will be priority number one. Obamacare, you're all well aware of the problems that exist today. So just a reminder, again, this is something you're living. You're well aware of those that have pulled out and the failed co-op program. The risk corridor, though, I mean, does everyone know what that is? So as part of the ACA, the deal was for those sicker patients and to keep plans and make sure there was access appropriate. The Obama administration asked and got from the Democrat Congress almost $3 billion in adjusted risk payments for those insurers. Those insurers built that into their payment models and their actuarial models. They were supposed to, just quick math, they were supposed to get $2.8 billion. To date, they're going to get about $330 million. That is more than anything driving why the insurers are dropping out of the markets. And then again, you're all well aware, but the average number, there are numbers much higher than this, but McKinsey said the average increase for the lowest cost silver benchmark plan is about 11%. So we know the impact from consumers and what they're saying right now. So we wanted to talk a little bit about some of the physician payment issues in Congress. You're all well aware that the SGR was finally repealed, and the Medicare Access and Chip Reauthorization, MACRA, replaced that last spring, largely with two new items, two new acronyms that I would guess you all are living or paying attention to. MIPS, the Merit-Based Incentive Payment System, and we should have capitalized it, the Alternative Payment Models. And CMS is expecting to release those regulations on MACRA in October. Again, cannot emphasize enough that the real action is in the regulatory world. Getting anything across in a bipartisan fashion, legislation, very, very difficult. And as you've seen from CMS, they are not slowing down, waiting for Congress. So for those that aren't aware of MIPS, it is intended to streamline and improve the quality measurements into one program. According to the proposed rule out of CMS, they're going to begin measuring performance through the MIPS starting in January of 17, with the payments based on those measurements 2 years later. CMS has said they hope to provide greater flexibility in that first year of implementation. The alternative payment models would provide a 5% lump sum payment to the physicians who are part of these qualified APMs, but not all alternative payment models are going to be considered alternative payment models. I can't tell you the definition because it is a gray area and it's kind of a case-by-case basis based on what CMS decides. But you can see the criteria that they have said in writing of how they will determine those APMs. Some of the verticals that they have outlined that will be included and supported is the comprehensive end-stage renal disease care model, the shared savings model, which is basically the accountable care organizations, the comprehensive primary care plus, and then the oncology model. CMS has said that this is not a static list. They will keep updating it. They're looking for stakeholder engagement, and certainly many provider and healthcare groups are going in and having those discussions. As part of the MACRA, they did set up a new technical advisory committee, which is meeting. It is a vehicle and opportunity for you to provide your issues to the panel. in theory, the committee's recommendations will be sent to HHS based on that input. So that technical advisory committee is a place for you to engage in. MACRA has been very controversial. Again, it was supposed to be the holy grail. We've got the SGR behind us. In Washington, what they are hearing and what the members of the key committees in Congress are sending to CMS on behalf of their constituents. So calling for more streamlined requirements, opportunities to participate in the alternative payment model, and as well as there are some discussions of delaying the program on a longer glide path. These are some of the other issues, issues like the risk adjustment policy, certainly debates over the measurements, asking for lifting of some of the Stark restrictions, as well as not just letting hospitals and other large systems control the dollars and the system, that physician-led groups should be able to control the dollars too. Republicans, of course, have a very different opinion, but they don't control the White House. So Paul Ryan, as many of you have heard previously, I'm sure, has called for a Obamacare replacement, a premium support model, as well as refundable tax credits to replace the exchange subsidies. Just a reminder that those that are in the ACA, about 85% of those individuals are getting some level of subsidy to pay for their premiums. The other point, though, that is very, very real and very, very serious is the public option is back. And Democrats in Congress want fixes to the ACA. Republicans continue to say no, let it fail of its own weight. But the Democrats, despite the political problems that come with supporting the public option, are out there today during a campaign season saying that a government-run public option should be back in play. So there was one bill that apparently your group and others have been working with a couple members on, the world's greatest healthcare plan, HR 5284. Introduced by great members and good allies, Dr. Cassidy and Congressman Sessions. It is another variation of the Ryan plan, where it would eliminate much of the ACA and provide tax credits to purchase private health insurance. Again, when you have divided government, divided Congress, they are not going to come together on such a controversial issue. And you can see other provisions here that would support your industry. It allows better and expanded uses of HSAs, which this administration has tried to significantly clamp down on. And it explicitly says that concierge medicine should not be treated as insurance coverage. So policy issues, again, I'm going to keep flying through this quickly. So we've talked a little bit about this. MACRA implementation will be one of the top health issues in the next Congress, as well as the issues around that are getting oversight review of provider consolidation, as well as system consolidation. So it's not just the insurer mergers that are getting attention and scrutiny, but other aspects of the healthcare system because of the rising healthcare costs. And that's really a bipartisan issue, even from people like Republican Senator Chuck Grassley. These are the issues that we expect to come up. Again, after this, you'll have our info if any of these are important to you, but these are the vehicles and issues that it is a very busy healthcare agenda in 2017, no matter who wins the election. Republicans are going to continue to push the value-based purchasing and some of the bundles that actually CMMI and CMS have been pushing. And also on the Medicaid side, Republicans are, with state block grants or some form of a capitated payment system. The Democrats, we've talked a lot about this, but the 3 R's, more dollars for the risk corridor program, bolstering the insurance program, and then risk adjustment, and then bringing the public option back into play. These are some of the goals. Again, if you have a continuation of a Democrat in the White House, Mrs. Clinton, We don't expect any of this to change, and it really has changed the landscape of healthcare completely, of the value-based purchasing programs, and HHS has a goal of at least 50% of the Medicare payments being VBP within the next 2 years. Just again, I'm going to kind of beat a dead horse here. The power of CMMI is power like we've never seen from a regulatory standpoint. In some ways, it's good. It is bringing innovative program. It is a pathway or an avenue for innovative programs. There's a lot of concern, though, that it doesn't have any real oversight, and it doesn't go through any kind of regular process. But again, no matter who wins the White House, CMMI is an incredible vehicle, and you can see the kind of things that have gotten done: the establishment of the ACOs, all of the bundled and episode-based payments, the readmissions programs you've been talking about, and the beginning of the medical home model. Elections, again, elections have consequences. So who wins this White House is going to largely determine and set much of the healthcare agenda. I don't think anyone can really predict what is going to happen. I think the smart people give Mrs. Clinton about a 60% chance, give Trump about a 40% chance today. This is just a reminder, like every presidential election, there's really only 7 or 8 states that matter. And you can see the colors coordinate to the states that the last election President Obama carried. Very, very close election. But in a traditional year, which this is not a traditional year, Mrs. Clinton has massive resource advantages, probably about 4 to 1. That being said, this has proven to not be a traditional year, as we'll all see on Monday night, where they expect almost 90 million people to watch the first debate, more than a Super Bowl. This is the map, though. If you're supporting Trump or you're against Secretary Clinton, either way, you can see, though, that a Democrat nominee basically starts in the red zone. Any Republican nominee has to draw basically a straight flush to be elected because of the demographic problems that Republicans have on the coast and take major electoral states out of play. The Senate, if you don't know, Republicans control 54-46. These are the states that matter the most: Indiana, Pennsylvania, New Hampshire, down up through Missouri, and Illinois and Wisconsin. Those are Republican seats, but currently are leaning Democrat. So again, you can see the map. This will be very, very close, and a lot of people predict they would not be surprised to see a 50-50 Senate, once again decided by whoever the vice president is. That's probably good for legislating as you look at issues that are out there. Having divided government, having people having to work together is probably a greater opportunity for some of your issues to be addressed. In the House, Paul Ryan is coming back as Speaker. They have the largest majority they've had since the Truman presidency. It's not a functioning majority because of the Freedom Caucus. They are likely to lose seats. You can see what the map looks like there from a House perspective. Again, you can see quote-unquote flyover states, which I come from, a lot of red, but the Democrat numbers all come from largely from the coastal states. Just put this up here as a point of reference for any of you. If you're from any of those areas, these are the races. Out of the 435 seats, these are really the only ones that matter and will determine the size that Speaker Ryan, the size of majority that Paul Ryan will have come November. Thank you, and I guess Robert and I will take any questions.
This is very fascinating information, and it's critically important to our future. It would seem to me, though, that the bureaucracy and the increased cost of managing medicine that has resulted from everything you guys just talked about is the best thing that ever happened to concierge medicine. Because as this escalates out of control and these costs go off the roof, more and more people are going to realize that personal private care outside the system is the only way we're ever going to solve this problem. Can you comment on that?
I'll go back to the comment I made, and I'll focus on Washington. That might be true on policy grounds and common sense, but this is Washington. And the inertia of strong, big entities like the American Hospital Association and what used to be AHIP are very large forces that, quite frankly, get the majority of attention and the majority of their agenda passed.
I would agree with that. I think that, again, there is a lack of interest in really, a lack of interest in, and there's just political ramifications to truly new areas, particularly at the state level. And so they're retreading the same ground that they feel comfortable on from a regulatory standpoint.
Well, thank you, you guys.
Yes.
Okay, we go have one question. Go ahead.
From the state and/or federal perspective, to put this sort of to summarize, do you see any discussions in any of this policy that is a direct threat to concierge medicine?
I think you really have to tell us that, meaning, speaking for Washington, these are the issues that are in play. And if any of those issues affect you, then raise your hand. I think from our understanding of concierge medicine, the answer is no, but I'm going to go back to this unknown of CMMI. These things coming out of CMS are coming out of left field. And there are very different philosophical differences of the two parties in Washington. And again, in this election, if it goes the way many people think it will, I think I would be very worried about what the next 4 years holds.